Christopher Ward, Murfreesboro, TN. Does anyone have any experience with having a view toward twisted coronary artery? Martin Drummond. I think I may have something like that, but when I complain my doctors never pay any attention. Christopher Ward. I went through that too, unfortunately. Back in the day I even had a cardiologist tell me that it was impossible for someone my age to have heart issues. Martin Drummond. I have complained about a stabbing pain that comes and goes in my heart and left lung area for years. I asked my doctors to look into having my lung vacuumed. I asked them to get my Excercize from my other doctors and look at them. I asked them to do ... Seymour Carol Berlin. Martin Drummond. Fire your doctors and find one who will listen. I just changed doctors because mine made me feel I was being psychosomatic when I talked about my symptoms. Martin Drummond. I quit the whole system. I quit the Kentucky system. I was on passport. They were robbing me and the taxpayer blind, so I couldn't deal with it and quit. So there are no doctors, no dentists anymore. Fuck them all. I will die like billions have died before me on my down. Christine Fueling. Christopher Ward. There are people in their teens who have heart attacks. You need a different cardiologist. Christopher Ward. Christine Fueling. I'm hoping he confers with the cardiac surgeon who did my ablation. I think my condition is beyond the capabilities of my present cardiologist. Martin Drummond. Facebook troll thugs marked my comment as spam. They can go fuck themselves too. Fact is, I don't consider my situation to be sad at all. I am free. They can use me to make money off the taxpayers. And in fact, that's all that was happening. They never did jack shit for my health, but they did manage to charge Medicare tens of thousands of dollars. Martin Drummond. And for you too. There is a cure. It's called exercise and weight loss and good nutrition. You have to moderate the exercise to suit your condition. But when done right over time, it will cure anything. Gaze Bound Body is a cure for AIDS. Can exercise help prevent and treat AIDS? Dr. L.J. Kovalkovic presents evidence on how exercise may help treat and prevent AIDS. And if so, the simplest, most widely available and affordable natural vaccine is being ignored. Introduction. The most effective way to control the HIV/AIDS pandemic would be the development of a safe and effective HIV vaccine. Unfortunately, despite enormous scientific and financial resources being deployed worldwide over the past 15 years, no vaccine candidate is on the immediate horizon but see Pink Panacea, an AIDS vaccine. This series. There are strong indications, besides, that the AIDS vaccines currently tested in humans are not only ineffective but also harmful. In addition, current medical therapy of HIV disease is extremely toxic, with multiple side effects and drug interactions. See AIDS and HIV. This series. It is also very expensive, and carries risks of developing drug-resistant HIV strains. It is clearly desirable to pursue other less toxic, inexpensive, non-drug approaches in order to slow the spread of HIV infection and to decrease the burden of HIV infection and treatment. The answer may come from certain antibodies that appear to be directly involved in controlling HIV disease progression. These antibodies have specific affinity, or cross-reactivity, to the HIV-1 envelope protein GP120 surface antigen, residues to 80302 designated peptide NTM, but may be naturally occurring autoantibodies, antibodies generated against the individual's own antigens against a small protein molecule that acts to dilate the blood vessels in the intestine. Vasoactive intestinal peptide VIP. It so happens that aerobic exercise training stimulates the formation of these anti-VIP/NTM antibodies in both normal and HIV-positive individuals, and perhaps both could benefit from such exercise. Increased levels of anti-VIP/NTM antibodies induced by exercise may have two beneficial effects. First, in HIV-negative individuals, the anti-VIP/NTM antibodies could bind HIV particles in circulation and prevent them from reaching their target cell, thereby reducing the risk of infection with HIV and decrease the transmission of the disease. Second, in HIV-positive individuals, increased levels of anti-VIP/NTM could slow HIV disease progression and reconstitute the damaged immune system. Aerobic exercise may be an important, inexpensive, non-toxic, widely available front-line defense and therapy against HIV/AIDS. By acting as an immune stimulant for both HIV-positive and HIV-negative individuals, it creates a type of natural vaccine that, if widely adopted, could contribute to a worldwide slowdown of the AIDS pandemic. HIV and AIDS disease. The first step in HIV infection involves the GP120 on the outer envelope of the virus binding to receptors on the cell surface of the host, allowing the HIV virus to enter the cell. The central portion of the GP120 molecule has an immunoglobulin-like structure, which facilitates participation in the immune network. Therefore, immediately after infection, HIV tries to produce a fit to the host idiotype individual type by producing thousands of variants of GP120. This process of adaptation usually takes years, and during this time, the host immune system is more or less able to control the HIV disease. In some HIV-infected persons, this period is short, and in others it can be quite long, giving rise to the designations slow and fast disease progression. After this latent period, a separate fraction of viruses will be established whose GP120 carries the host idiotype. This population of HIV becomes accepted by the host immune system as self and therefore protected from the host's immune attack. Even worse, these GP120 molecules will be included in regulation of the immune network, destabilizing its vital components and accelerating progression of disease. In this way, HIV may escape from the latent period and progressively destroy the immune system of the infected person. The GP120 protein represents the key component of all AIDS vaccine candidates that are currently in clinical trials. These vaccines may have an important flaw in that they produce antibodies that neutralize only the HIV variants, which carry vaccine like GP120. As the variants of GP120 are produced by the HIV infection, the vaccine antibodies may have the effect of disarming the immune system's antiviral response and thus increasing the likelihood of rapid disease progression. This phenomenon has been seen in GP120 vaccine volunteers who later became infected with HIV, and would certainly reduce the utility of an HIV vaccine in AIDS prevention. Useful autoantibodies in HIV disease. If an Achilles heel exists in HIV, it might be in the central portion of GP120 residues to 80302 RSANFD DNA CTIIVQL and ESBIN, designated as peptide NTM. The letters stand for different amino acids. R equals arginine, S equals serine, A equals alanine, N equals asparagine, F equals phenylalanine, T equals threonine, D equals aspartic acid, C equals cysteine, I equals isoleucine, V equals valine, Q equals glutamine, L equals leucine, B equals glutamic acid. This portion of the molecule is highly conserved in all known HIV variants and appears to be crucial for viral infectivity. In fact, researchers have demonstrated that minimal changes in this sensitive peptide region will completely abolish HIV infectivity. Unfortunately, this part of GP120 is not immunogenic in humans because the immune system treats this part of GP120 itself, possibly due to peptide S similarity to several human proteins. However, an antibody found in both HIV-positive and HIV-negative individuals seems to have reactivity to this region of the GP120 molecule. The computer-assisted search of the Swiss PROT database reveals vasoactive intestinal peptide VIP as the best match to NTM among currently analyzed human proteins. The antibodies reacting to NTM may therefore be autoantibodies against VIP. VIP is a small, naturally occurring peptide, which plays several important roles in the human body as a vasodilatator, dilates blood vessels, neurotransmitter, and modulator of the immune system. VIP stimulates natural killer NK cells in the immune system among the first line of defense against infection, and also the production of cytokine, the hormone that influences the activity of other cells in the immune system. VIP therefore has a very important role in modulating the immune system. The HIV protein GP120 is sufficiently similar to VIP to serve as a molecular mimic and interfere with its function. The main consequence of this mimicry is to undermine the NK cells, making them dysfunctional, which is common in HIV-infected subjects. As Peruzzi and co-workers demonstrated, GP120 inhibits the ability of NK cells to kill infected cells, and this inhibition affects also the production of the pro-inflammatory cytokine IFN-gamma, which enlists the help of other cells in the immune system to fight the infection. Thus, increase in circulating VIP can counteract the effects of the HIV GP120 by overcoming the latter's inhibition of NK cells, and by stimulating the production of VIP autoantibodies which can also bind GP120 and prevent it from binding to NK cells. Finally, both VIP and the peptide NTM has been previously identified as possessing sequence characteristics responsible for the interaction between HIV and the CD4 receptor, which represents the first step in process of infection. It has also been demonstrated that serum from HIV-negative asthma patients contains high levels of natural anti-VIP antibodies with peptide NTM reactivity. The recent study on serum from 393 HIV blood donors found that approximately 5% 21/393 contains significant levels of the anti-VRP/NTM antibodies, corresponding to 2 standard deviations above average. For HIV+ individuals, the amount of anti-VRP/NTM antibodies available appears to strongly correlate with progression of HIV disease, suggesting that the immune system is attempting to overcome the infection. HIV patients in the first stage of illness characterized by CD4 lymphocytes count greater than 500/ml when the immune system is efficiently controlling HIV, have very low levels of anti-VRP/NTM reactive antibodies, similar to levels in normal HIV people. The level of these antibodies significantly increases in disease stages corresponding to CD4 values between 200 and 500/ml. Below that CD4 level less than 200/ml, however, the amount of anti-VRP/NTM antibodies sharply decreases. In the terminal stages of AIDS disease, NTM reactive antibodies in sera of HIV+ patients appear to be significantly decreased. Noyrock and co-workers have also reported differences in the spectrum of antibodies against HIV-GP120 into groups of HIV-infected individuals, those who remained healthy for at least 10 years, and those who developed AIDS within 5 years of the onset of infection. They found antibodies recognizing the peptide 280-306 of HIV-1-GP120 overlapping NTM significantly more prevalent in asymptomatic carriers than in AIDS patients. Thus, the absence or disappearance of these antibodies may be a possible factor contributing to the development of AIDS. Exercise as a natural source of VRP/NTM reactive antibodies, a unique method to produce high titers of VRP/NTM reactive antibodies, may be available to both HIV and HIV+ individuals. An article by Paul and said in 1988 showed that autoantibodies to VRP were present in plasma from 29.6% of healthy HIV human subjects who habitually performed aerobic muscular exercise, compared to 2.3% of healthy subjects who did not. The exercise involves running, cycling, swimming, aerobic dancing, and / weight training, 3 or more workouts per week for a year or more prior to the study. The antigenic stimulus for the formation of these autoantibodies could not be identified from their data. However, acute exercise has been shown to be associated with a brisk increase in plasma levels of VRP. It is possible, therefore, that the antibodies may have been produced in response to increased VRP levels during exercise. The effect of aerobic exercise training on HIV-positive individuals. Several studies on aerobic exercise training in HIV-positive individuals have demonstrated that it is safe, effective, and has a number of beneficial outcomes. The aerobic exercise fitness improvements include a 10 to 25% improvement in lactic acidosis threshold, a sign of fatigue, and 5 to 10% increase in maximal oxygen uptake depending on the exercise training intensity. In addition, despite concerns about the stress of aerobic exercise on already damaged immune systems, specifically increases in infections, morbidity, or mortality. There have been no documented adverse effects of aerobic exercise training in HIV-positive patients at either moderate or heavy exercise training levels. The available literature clearly supports the idea that aerobic exercise is well tolerated by HIV-positive individuals. With regards to immunologic improvement with aerobic exercise training, CD4 counts or viral loads may or may not improve during the exercise intervention in exercise. See below. Although skin test reactivity to Candida antigen has been shown to improve with moderate exercise, the quality of life outcomes, however, were found to have improved significantly with aerobic exercise training relative to a non-exercising control group. There are indications that exercise can stabilize CD4 cell count in HIV-infected individuals. Studies showed that people with CD4 cells between 200 500/milliliters seemed to benefit the most from an exercise program. A pilot study performed by Olson and co-workers found that the mean change in CD4 percentage over the 24 months interval for weightlifters was -3.1% compared with -5.9% for runners. According to these researchers, among HIV-infected patients motivated to and capable of regular strenuous exercise, weight training may offer a salutary benefit superior to intense running. The same authors have also reported the case of a long-term survivor 12 years HIV+ of a triathlete with a rigorous daily exercise regimen demonstrating very low viral burden as reflected in non-detectable HIV-RNA quantitative PCR, an increase in CD4 during 6 years from 3 to 50/milliliters usual. CD4 cell count is greater than 800/milliliters. There was a report that exercise facilitated the return of the CD4 cell count to more normal levels in a large study involving 415 individuals, 156 HIV-positive and 259 HIV-negative. Mustafa and co-workers demonstrated that exercising 3-4 times week had the more protective effect than daily exercise. Exercise in the HIV-positive group covered by this study showed an increase in CD4 count during a year by a factor of 7%. It should be noted that some authors have reported moderate training can be sustained without any large change in CD4 cell count. Exercise for the masses. Aerobic exercise training has been shown to be a promising, non-toxic, non-drug adjunct therapy to improve physical fitness, increase quality of life, and potentially improve the immune status as indicated by reactivity to Candida skin test of HIV-positive individuals. If aerobic exercise training can also be shown to increase the titer of anti-VIP/NEM antibodies in normal individuals, potential to decrease the risk of HIV transmission, and in HIV-positive individuals potential to slow disease progression, it would strengthen its case to serve as a widely available and affordable intervention that is non-toxic and free of drug interactions. It would be applicable worldwide, in both developed and developing countries. Article first published June 4, for Martin Drummond. So if it can cure people of a debilitating disease like AIDS, then it can certainly cure most other lifestyle-type illnesses. HIV and AIDS patients find exercise improves their health by Sam McManus. April is Sexually Transmitted Diseases Awareness Month. In the U.S. alone, there are 19 million new cases of STDs each year, according to the American Social Health Association. Half of the new cases are among those between the ages of 15 to 24. Never an athlete. Simply from lack of interest, not lack of innate ability. Travis Tanner at first did not realize the magnitude of the challenge that lay ahead. Still, a challenge was exactly what Tanner, 29, sought. He had just come out of a darkness so intense that he could hardly bring himself to leave his Midtown Sacramento, California, apartment. His life had been in a downward spiral since February 2003, when he tested positive for HIV. Drug addiction and depression gave way in the past year, though, to a renewed interest in work and college. And Tanner was ready to try something else, something healthier. So when he saw the flyer for the Norcal AIDS Challenge, a 4-day, 325-mile charity cycling event, he thought, why not? On a borrowed bike, he hit the American River Trail one day full of hope. I could only go 10 miles before being winded, he recalls. But I started getting better right away. Now, he's doing 100-mile rides with relative ease, lifting weights regularly at a gym and talking about hill climbing like an experienced cyclist. This is definitely the best shape I've ever been in, says Tanner, whose light body shows distinct muscle definition. And it's ironic because I got so sick when I first became HIV positive, and now I'm the healthiest I've ever felt. Hearing such a refrain is not unusual among HIV and AIDS patients. In the decades since protease inhibitor medications have helped manage the virus, many patients have either begun exercise regimens or resumed endurance training with a vengeance. Mounting evidence suggests that exercise not only provides a boost to well-being, but also can help the immune system fight off illness and AIDS-wasting disease by increasing muscle mass and improving heart and lung endurance. In addition, the 2006 Massachusetts General Hospital study found that exercise manages symptoms of metabolic syndrome, which increases the risk of heart disease and diabetes. Reports say as many as 45% of HIV-positive patients have metabolic syndrome, and a 2005 Columbia University study found that moderate exercise, in combination with antiretroviral drugs, led to improved nervous system function and circulation in HIV patients. Such preliminary reports are heartening to people living with HIV. Even so, many say that they would be exercising even if it showed no healthful indications. For me, the effects are more psychological than biochemical, says Bob Katz, a member of the Positive Peddlers, an HIV-positive cycling club in California with a membership of around 275, mostly in the San Francisco Bay Area and Los Angeles. Having a sense of self-worth, feeling comfortable in your body, is something exercising will do. We HIV patients need to be able to pay attention to what our bodies are telling us. There's nothing like physical exercise to make you aware of what's going on in your body. Dr. Archana Mainier, an infectious disease specialist and assistant professor at UC Davis, agrees that HIV patients are no different from non-infected people. They need proper exercise. With the advent of antiretrovirals, patients are living long enough to get the diseases everybody else gets: diabetes, hypertension, cardiovascular disease, strokes, Mainier says. From that standpoint, Exercise promotes their general wellness and increases their chances of avoiding those things. Some HIV patients are concerned about being prone to complications if they exercise a lot, and I tell them that listening to their body is the key, just like for anyone else. A few HIV-positive endurance athletes say they have never let the disease limit their activity. Perhaps the most noteworthy is Excercize Munoz, 50. The Los Angeles marathoner featured in the widely aired 1995 Nike TV 80. It showed him running through the Malibu hills and ends with this message: 80 miles every week. 10 marathons a year. HIV positive? Just do it. And Munoz has done it, over and over. He tested positive for HIV in 1987, 4 years after he started running. He remembers telling the physician who gave him the news that he was a marathoner and he had no plans to give it up. This was, remembered, before any enhanced drug regimens were developed. If he had objected to that, I would have found another doctor, Munoz says. All these years later, Munoz is still running. He completed last month's Boston Marathon in 3 hours, 22 minutes, a time he wasn't happy with. He's training now for a 56-mile ultramarathon in South Africa. Over the years, Munoz says, running as much as 80 miles a week hasn't affected his health and does not adversely interact with the drug cocktail he takes. I always thought it was a genetic thing, the way some folks are better able to fight HIV, he says. 10 years ago, deep into his running career, Munoz chose to stop all medication. That experiment lasted for 3 years. My doctor said, grave accent, I am not going to force you to take it, but I can't guarantee at some point you'll come down with an opportunistic infection, Munoz recalls. And I did. It was cryptosporidiosis, an intestinal infection. But even when I wasn't on medication and my T cells were dropping, that didn't affect my marathon performance. Once he returned to his drug regimen, Munoz says the condition went away. Since then, he boasts, he's running nearly as much as ever and I've built T cells up to undetectable range. Not all HIV athletes have been as fortunate. Larry Teeter, a 48-year-old AIDS patient and a biomedical researcher at the Baylor College of Medicine in Houston, has run 108 races of marathon length or longer, including the Western States 100 endurance event in 2004. All this, despite losing vision in his right eye as a result of AIDS-related CMV retinitis in 1994 and, in 2005, suffering from avascular necrosis, bone deterioration due to lack of blood supply in his right hip. For years, Teeter ran with an IV catheter poking out of his chest. Now, he takes antiretrovirals early, and his hip degeneration was corrected after surgery in 2005. Teeter says he has seen the ravages of the disease take a toll on his body, and he says he's not sure whether his exercise routine has hastened the decline. He just knows he doesn't want to stop doing it. Certainly the muscle mass is there for the legs, but I have the loss of body fat and facial wasting that's characteristic for HIV patients, he says. And there are some studies that suggest marathon or longer events might be detrimental to your cell count. But that's countered by Richard Brodsky, an HIV-positive New York man who runs a marathon each month. Brodsky says his cell count has been 900, higher than they've ever been. But Brodsky also has brain cancer, which he says his doctors have determined is not related to his HIV status. Exercising keeps him alive, he says. A lot of it just has to do with, pardon the pun, being positive about it, Brodsky says. When I run, I tend not to get colds or any of the opportunistic infections. Some days, it feels like the HIV isn't even there. For Tanner, the Sacramento cyclist, extreme endurance events probably won't become a habit. But he says he definitely will continue exercising after the 4-day AIDS ride. It makes me feel better about myself, Tanner says. When I go on a ride, the first few miles I'm thinking, grave accent of, why am I doing this? Then I go through what I call the wall and I get into this zone, just me and the bike. It's kind of meditative, you know. See 2008, the Sacramento Bee, Sacramento, California. Visit the Sacramento Bee online at http://www.sacbee.com/distributed by McClatchy Tribune Information Services.